everyone, and welcome to our educational series titled PET Tumor Board. In this series, we present real-world cases, mostly drawn directly from my clinical practice, with the goal of highlighting practical scenarios and extracting meaningful, applicable learning points. Joining me for today's Tumor Board are several renowned experts in the respective field. Dr. Dan Petrylak, medical oncologist from Yale, Dr. Sherief Gamie, a nuclear medicine physician from the University of California, San Diego, and Dr. Wayne Brisbane, a urologic oncologist from UCLA. Also joining us is Dr. Sean Collins, a radiation oncologist from the University of South Florida. None of our panelists have reviewed these cases in advance, ensuring fresh, candid insights. Let's dive in. So, this is a patient that I saw recently from actually Naples, Florida, that came to see me out in San Diego. Was referred by a friend of mine, and he is an entrepreneur who, at age 62 in 2017, had a radical prostatectomy. And that was a Gleason, and it was actually done in Italy, but he had a Gleason score of 7 negative surgical margins. For some reason, right after his surgery several years later, he had a PSA of 0.81, was treated with radiation and 4 months of hormonal therapy. Interestingly, he also was germline tested and BRCA2 positive. He came to see me after his PSA began to rise. So after the radiation and the hormone therapy limited is on the right here, you see his PSA was down, but then it began to rise in early 24 when right before I saw him, it was 0.14. And during our visit in March, it was 0.19. What's the next step? Who wants to chime in here? Dr. Collins?
I would get a PSMA scan.
Okay. Nobody would disagree.
Seems
So, in fact, that is what occurred because this is a PSMA PET tumor board. So the postluma scan comes back, read by Dr. Sherief Gamie as basically negative. There's no local recurrence, no regional disease, but he does comment on a rib. So Sherief, why don't you dig into this a little bit deeper about lesions and false positives and negatives?
We keep coming across this rib findings that just throw everybody off. And I think if there's clearly no definite corresponding osseous abnormality, and I say that with a grain of salt because sometimes if the osseous changes are sub-centimeter in size, this is where I'm at a disadvantage and I won't see it, and so I won't call an osseous finding. But in the absence of a clear-cut osseous finding, I would either chalk it up to post-traumatic or fibrous dysplasia kind of scenario, and not hang the hat of the rising PSA on that rib finding.
That is an important statement because that seems to one of the things we see all the time on the PET scans. And I'm going to ask you if there's any difference between some of the PETs out there, and that it really throws people off in what they want, how they treat the patients. Particularly, I guess if you had multiple ones, you'd feel different, right?
Absolutely, absolutely. If there's
How do
one,
you investigate this? MRI? What do you do?
I think an MRI can help. I think the first step would be ask the patient, "Have you got bumped there recently?" Because a lot of times that it gives you the answer and it kind of just puts it to rest. An MRI would be a good next step to completely rule it out. But I think the other alternative would be to just get a follow-up study in a few months as far as PSMA.
Are the insurance companies going to pay for that? I wonder. Yeah. What is there any difference between the different scans in rib positivity. Seems like when we first started out in this, we were seeing more more positive ribs, but is that is,
So we started out with gallium-68 PSMAs, and gallium-68 is a tracer that just its physical characteristics in terms of how it decays produces a photon that is not as well imaged by our quote unquote crystals that are part of the PET scanner. And so since we've a lot of the practices now have shifted from gallium-68 to F18, whether it's Posluma or Pylarify. F18 has a little bit better imaging characteristics, and so there's not that much amount of
Hmm?
would we scatter, if you will. And so that's why it's gone down a little bit. And Dr. Collins, you mentioned looking for something that's 0.5 centimeters or larger. That's for the new scanners. Older scanners are probably closer to 0.8. And so the technology now is out there 0.5. But if it's something that's smaller than a half a centimeter, it's anybody's guess.
okay.
That was really helpful. Thank you.
So Dan Petrylak, medical oncologists often are the sort of supposed to be middle of the road people between radiation oncology surgeons to render opinions in cases like this. What would you tell this guy?
So, again, I think this rib lesion's a complete red herring based upon his clinical presentation. And with a negative PSMA PET scan, you could radiate his bed. That's one possibility. You still are below that 0.2 threshold where it's considered to be a relapse. So again, I think you could potentially observe this patient as well. It's really radiation therapy now versus delayed radiation therapy.
Let me ask Dr. Collins. If Dr. Petrylak wasn't sure and he sent this patient to you for radiation, what would you do?
I read the records and he had 71.8 gray to his prostatic fossa already.
Oh, I
Uh,
made that okay.
Yeah, I mean,
Was that I didn't see that before actually.
yeah.
Oh, missed that.
I mean, to me, re-irradiating someone who's had prostatic fossa radiation would be highly dangerous and put him at risk for many things.
What about the rib, though? That's what I'm talking about.
The rib. For the rib, I would not radiate that. I see lots of rib lesions that does not have any, there's no obvious soft tissue component to it. And so to me, I would not radiate the rib. I think it's unlikely to be the cause of that, the source of that PSA.
Okay. Anybody else have any comments?
One of the things we also could consider, even again, the PSA is below 2, but if the PSA goes up and there's no change in the scans, you could also consider giving single agent enzalutamide to this patient.
Yeah.
Okay. I think that so we talked about, should we repeat the scan? We talked about that. If you repeated the scan, Sherief, if you were worried about that or something else, how long would you wait? 3 months, 6 months, what?
I don't know if there's a real good number. I would look at the doubling time of the PSA. I mean, if his PSA is steady and it's just minor bump up in PSAs, I'm not sure that you could get it anytime before 6 to 8 months, probably closer to 8 months, I would say. But if the PSA is doubling or if it's rising fairly rapidly, I think you can make a case to get it probably as soon as 6 months.
So, Blaine, what is your definition of a rapid doubling time when you're looking at PSA as a urologist?
I mean, in this kind of clinical scenario, you could, and Dr. Petrylak will have to clarify this for me, but I think you can use the embark criteria, which is that 13 months or 16 months? It's
I
I can't remember.
I believe it was 12 months.
12 months. Yeah, it's pretty short. So I think any time where your PSA doubling time is less than a year, that's considered fast by almost anybody's definition.
Okay. Well, great cases. A lot of this is a great case here. A lot of learning points about rib lesions and doubling times and things like that. Let me just ask Sherief this question and the rest of you. What's the lowest PSA level with biochemical recurrence that you would consider ordering a PSMA PET scan?
Be uh, obviously knowing what the approved indications and pre-auths that are 0.2 is probably That's the published known. But we've discussed a couple cases here today where the sentiment and the recommendation was to get a PSMA scan even under 0.2. So I think any rise in PSA really that is either making you, the urologist, the oncologist, the radiation oncologist nervous, or the patient is kind of now concerned, probably makes sense to go ahead and order it since it's rising. Again, if it naders and if it gets to undetectable.
Last comment, Wayne?
No, I agree. That is a nice case. The one thing I do wonder about is probably from an individual patient standpoint. I feel very vindicated when I'm being aggressive. From a cost standpoint, then I'm not sure what the right answer is.
Great. Let's just summarize what we've learned from this case. First of all, we discussed PSA levels at which time to perform the test. Green on 0.2, but there are a lot of men that have positive tests when their PSA is less than 0.2 nanograms per ml. Kind of reminds me of bone scans years ago, and before we published the Radar 1 paper, in which we showed that ordering bone scans a lot of times in men with PSAs of less than 20 is not very helpful, but there's always those exceptions, particularly with higher grade cancers. So we continue to move forward, and we do know that it also serves another purpose, and that's a baseline to compare to in the future. We talked a little bit about when to repeat these, and I think we're in a learning curve. They're very helpful at monitoring lesions, but I would say that it's important to do this if the results are going to be actionable, that we're going to do something with it. And finally, we discuss lesions away from the pelvis, particularly like ribs, that sometimes sort of in a red herring here and doesn't mean anything. So again, I want to thank everybody for taking part in this PET Tumor Board.